Good morning, everyone, and welcome to today's Lunch and Learn. My name is Michelle Snow. I'm Patient Education Librarian here at Princess Margaret Cancer Centre, and I will be introducing our speaker today. Cailey Crawford is the Ontario Regional Director at Ovarian Cancer Canada. Ovarian Cancer Canada is the only registered Canadian charity solely dedicated to overcoming ovarian cancer. In her role, Cailey connects those living with the disease and their families with information and support. She also raises awareness about the disease that is often overlooked and underdiagnosed with healthcare professionals and with the general public. Cailey's background is in education and health, and prior to working at Ovarian Cancer Canada, Cailey was the Director of Strategic Partnerships at the Canadian Education Association, investigating systemic challenges associated with public education. So we're very happy to have Cailey here today, and this is perfect timing because September is Ovarian Cancer Awareness Month. So please join me in welcoming Cailey.
Thank you, everybody. I'm really pleased to be here. I understand there may be a bit of a mix in terms of who is in the audience, and I hope that my presentation addresses what you're looking for. Just so you have a sense of where I'm going with the presentation, I'm going to focus a little bit on the disease itself, on information that would be really valuable to just for your own personal health and wellness information. But as well, I'm going to shift in afterwards to a bit of information about our organization and what we can do to help support patients who are living with ovarian cancer with their families, how you may, if you're a volunteer here or staff here, or if you're a patient or you have a loved one with the disease, how you can look to our organization and what resources you can help direct people to seek out from us. So I'm really pleased to be here. Just to get so we're on the same page, I just wanted to give some facts about the disease. So every year in Canada, about 2,800 women are newly diagnosed with ovarian cancer. So that doesn't capture any kind of recurrence, but those are newly diagnosed cases. It's not the most common cancer. The general public has about a 1.4% chance of developing ovarian cancer. That's 1 in 71 women. So when you compare that to something like breast cancer, that 2,800 figure is actually 25,000 women in Canada are diagnosed with breast cancer every year. And it's an almost 12% lifetime probability of developing ovarian cancer in your lifetime, so 1 in 9 women. So you can understand how you may know a lot of women with breast cancer, but you may not be as familiar with women with ovarian cancer. But sadly, 5 women die each day of this disease. So although it's not as common, it is a disease that should be on all of our radar. And that's why we're very much wanting to get out and talk about this particular cancer and to inform people. And part of the tricky nature of ovarian cancer is its complexity and the fact that it is most likely diagnosed at late stage. So most women, when they're diagnosed with ovarian cancer, have a diagnosis of stage 3C. And so why is that? So some of the reasons behind this. One is there's no reliable screening test that helps us detect this early. There's no mammogram we can go to. There's no colonoscopy. There's nothing we can do to screen for the test. And yet, a large percentage of Canadians actually believe there does exist a screening test. So a lot of women feel that if they go and they get their Pap test done regularly, they're covered, which also has that added element of women tuning out when you do start talking about ovarian cancer. So, they assume, and I did as well for quite a long time, that as long as I'm going and getting the Pap and whatever else happens in that appointment, something is screening me for this disease, and I don't really have to pay attention to it. There's also no vaccine that helps prevent against ovarian cancer, but again, almost a quarter of Canadians believe there is. They believe the HPV vaccine protects them. And I get so many questions about the HPV vaccine, and I finally have to say, the Pap test, the HPV vaccine, this is related to cervical cancer, not ovarian whatsoever. And that's a bit of a sort of a challenge for us when we're trying to raise awareness about this. So this is very much a reason why early detection is quite a challenge. There's no sort of early detection or preventative measure for the general well public. On top of that, there is no symptom that really is associated with ovarian cancer specifically that causes alarm. So if we find a lump, or if we have blood in our urine, or if there's some symptom that really gets our attention, we're off to the doctor. But as I'll talk about in a few moments, symptoms for ovarian cancer are so vague. We all have them from time to time. And so, again, that's a bit of a challenge. It doesn't really elicit a big reaction from either a woman experiencing the symptoms or even the family doctor. The diagnostic tests that are available aren't always accurate. So I'll talk a little bit about that. But honestly, this is quite frankly a disease that spreads quite quickly and suddenly. So, and I'm going to be very careful when I talk to you today about symptoms. This is just a disease. It's epithelial. Most commonly, it's an epithelial cancer, as we call it. And that means that the cancer cells get to the surface of the ovary and they just slough off into the abdomen before you even have a symptom, before a symptom can even develop. So it spreads fast, and it spreads in a way that's not that conventional, growing of a mass and then you feel a symptom and you catch it early. So it's just a very tricky disease that way. So I'm going to show a slide which kind of gets to this complexity, and it's nothing we're looking for you to take in any big way, but just to paint a picture. So ovarian cancer, we talk about it like it's one disease, but really it has subtypes, and it even has subtypes of subtypes. So just to give you a sense. So 90% are epithelial in nature, but there's also germ cell for 5 to 10%, and there's also sex cord stromal. So those are sort of three of the main subtypes. And then under each of those, you have various other subtypes. So high-grade serous, which is 70% of the 90%, is the most common form of ovarian cancer. But there's also endometrioid, clear cell, mucinous, low-grade serous. And if I had a bigger slide, I could go down. Sex cord stromal can divide into subtypes. Germ cell can be different subtypes as well. So this is a complex picture, which makes let's come up with a screening test a bit complicated, because we're talking, these all have different, they respond to treatment differently, they all react differently, and they're quite significantly different from each other. Just to point out, because I will be talking about inherited genetic mutations that increase your risk of ovarian cancer, when you hear about the BRCA mutation, that is related to high-grade serous only. So BRCA is related to high-grade serous, but there's something called Lynch syndrome as well. Those are related. That's related to endometrioid and clear cell. So again, very different from each other, and kind of creates that complex picture. So I'm going to talk to you about symptoms, and the thing we always talk about at our organization is once you start working at Ovarian Cancer Canada, you book a doctor's appointment within about 2 weeks of starting, because you read these symptoms and you're like, well, I have all of these, or I have some of these. And so I'm just going to review them, and hopefully by the end of this slide, you'll know when to pay attention to them and when you can relax a little. So the most common 4 symptoms are bloating, feeling full quickly or difficulty eating, pelvic or abdominal pain or discomfort, and urinary symptoms, so feeling that increased frequency or increased sense of urgency. So those are the top 4. Other symptoms can be fatigue, GI symptoms, change in your bowel habits. So some women will say, I had diarrhea one day, then I was constipated the next. I didn't know what was going on. Things were really changing. Menstrual irregularities, and weight loss or weight gain. So these are things we all have from time to time, and especially women, our bodies go through so many changes. We are so used to our bodies doing everything in the book. I'll just get to the end of this and then I'll answer your question in just a sec. So you go through puberty, you might get pregnant, you go through menopause. We are used to things changing. So when on earth do you react to this? And because most times you're not going to go to a doctor because you feel a little bloated. So our rule of thumb, and it's shared by the experts out there as well, is that if this isn't your normal, if this is kind of new to you, but you're having even one of these symptoms fairly consistently for 3 weeks, then we encourage you to book an appointment with your doctor, and then I'll go on from there. But I just wanted, you had a question?
Age plays a very prominent role in various types of cancers. If it's prostate cancer, you don't have to worry about it until they're 60. And the conventional wisdom of breast cancer, if you're, let's say, under 35 and there's a lump, think of something else before you think about cancer. What age group are we dealing with ovarian cancer? Okay,
so I will get to that when I get to risk factors. Okay, and there will be time at the end as well for some questions too. So hopefully if I don't answer anything, I'll be able to do it there. Okay, so if you have one or more of these symptoms for 3 weeks, not your normal, then we say go to the doctor. And what we encourage doctors to do is to conduct 3 tests, pretty much together, because any one of these tests can miss a diagnosis for sure. So pelvic exam, this is a digital, like using fingers vaginally, rectally to feel for a mass is one way. Transvaginal ultrasound, so this is with the wand, so this can also help detect ovarian cancer, and a CA-125 blood test. And this is interesting because this comes up all the time, the CA-125. A lot of, it looks for a tumor marker in your blood, and it works so well for some women with ovarian cancer. It's an excellent indication of whether there's ovarian cancer in her system. However, it also totally and utterly fails for other women with ovarian cancer. So you can have someone who's stage 4 ovarian cancer with a totally normal CA-125 level. You can have somebody without ovarian cancer whose CA-125 is through the roof for other reasons. So it's got a lot of false positives, a lot of false negatives, and that's why it's not appropriate as a screening test on the general public, but as part of sort of a bundle of diagnostic tests, it can provide a clue. And the point of the 3 tests is that your family doctor will get, or your gynecologist will get a sense of, okay, is ovarian cancer in the picture? And if from these tests they feel that it is suspected, what is recommended is that a woman should be referred to a gynecologic oncologist to do any kind of diagnostic surgery. The only really definitive way to diagnose ovarian cancer is through the pathology that comes from surgery. So a gyne-onc would be the appropriate person to do that. And it has been shown through research to have better outcomes. So that is, those are some of the options. Now, in terms of risk factors, age is absolutely probably one of the biggest risk factors if you're over the age of 50. So the majority, the average age of diagnosis is around 63, 64. But I want to be careful with this. That is just the average. Obviously, anyone with ovaries can have ovarian cancer. There have been children diagnosed, teenagers, young women. That it's not to say that everybody is always over the age of 50, but that is the age. That is the majority of cases. We really strongly suggest, because you can't just go for a PAP, because there is no vaccine, really get to know your personal and family history with cancer. And we really hope that when we talk to the general public, that this is a message we really strongly try to convey. Do you have a history of ovarian and breast cancer in your family, either side of your family? If so, you may wish to speak with a genetics counselor about the possibility of having a BRCA1 or 2 mutation. Do you have a history of ovarian, uterine, or colorectal cancer? That may be a clue around Lynch syndrome, another genetic mutation that can increase your risk of ovarian cancer. So this is one group we really try to reach out to and make sure that people know their history, and if they have a family history, they should be talking to a genetic counselor just to find out some of their options, and I'll talk about that in a moment. If someone is of Ashkenazi Jewish descent, then this is also incredibly important to know and to consider. The average, I think the general public, it's a 1 in 400 chance of having a BRCA mutation. If you're of Ashkenazi Jewish descent, that's as high as 1 in 40 chance of having a genetic BRCA mutation. So this is a lot of times when you talk to genetics counselors, they'll say, we don't require as much family history if someone is of Ashkenazi Jewish descent. We will actually go through for genetic testing and recommend it's covered because they're Ashkenazi Jewish, and maybe there's a couple of cases, but they will actually take that much more seriously because of that stronger chance. And so the main, the biggest risk, increased risk of ovarian cancer, is if you have a genetic mutation. And so why this is so important to find out, because I have to point out too that the majority of ovarian cancer cases aren't linked to a known genetic mutation. Only 25% of all ovarian cancer cases are linked to BRCA or Lynch. But if you are in the category where you have one of these mutations, you are actually in a very small group of people who can do something to actually prevent getting this disease, which is such a rare opportunity with ovarian cancer. So we very much encourage people to know, like, knowledge is power, so know what your genetic conditions are in terms of increased risk of ovarian cancer so that you could talk to a doctor about having your ovaries and your fallopian tubes removed as a preventative measure. And the reason it's so important is if you look at BRCA1, for example, your risk goes from that 1.4% risk, lifetime risk, to as high as 60. So this is an important group for us to reach out to. Because there's actually some exciting opportunities for them to consider in terms of preventing. And so, of course, we've heard about Angelina Jolie for a lot of reasons this week, but we've heard about her experience with BRCA and her decisions to have, a double mastectomy, to have her ovaries and her fallopian tubes removed as preventative measures, so that she never has to tell her children, as she says, that she's had breast or ovarian cancer. So it's a great opportunity here. I want to shift gears to another preventative opportunity. And that is that, and this has nothing, I just want to be really clear because sometimes it gets confusing. I've shifted away from inherited genetic mutations. This is for the general public now. The high-grade serous ovarian cancer, which was the kind of majority of cases of ovarian cancer, it's now been discovered, and they're becoming more and more comfortable saying this, that cancer actually originates in the fallopian tubes, not the ovaries. So what they are now recommending, and it's become standard practice in British Columbia, and it's becoming standard practice across the country and around the world, is that if a woman is going in for a tubal ligation or for a hysterectomy for non-cancer related reasons, that they talk to their doctor about having their tubes removed entirely because they don't need them anymore if they're going through those procedures. So just remove the tubes, and that would remove the chance of any ovarian cancer in those tubes from moving down to the ovaries and spreading. So that is another exciting opportunity. And I say exciting, it's not small, it's not a wonderful opportunity. It would be much better to have a screening test to help screen for this. But failing that, this is at least a chance, an opportunity to try to reduce the number of ovarian cancer cases. So that is just a bit of an overview of what we would talk to the general public about when it comes to ovarian cancer. And now I just want to shift gears a little bit and move to just some of the supports and resources that our organization can provide to women with this disease. And then, as I say, I will have time for questions at the end. So as Michelle mentioned, I'm not going to go over that information. We are the only charity dedicated to ovarian cancer. We are not affiliated with the Canadian Cancer Society or the Ministry of Health. We are our own standalone organization. And we have 3 pillars, and I'm going to talk a little bit about each of them. We provide support to those living with ovarian cancer and their families, increase awareness and educate the public, and we fund vital research. So I'll talk a bit about each. So part of my job as the Ontario director is I receive phone calls and emails from patients, from their family members who have questions or concerns about the disease, and I really do encourage this. So if you're ever speaking to a woman or their family member who has a lot of questions about things and you don't have time to answer their questions, please feel free to refer them to me, and I have business cards and support brochures up here if you're in a role where you might be speaking with somebody about this. So prior to diagnosis, I often get calls about symptoms. Should I be going to my doctor? My doctor isn't taking this seriously. He's referring me to a gynecologist to do the surgery. When should I become concerned? So I get a lot of phone calls at that point, and also between the point of when their doctor suspects ovarian cancer and that first appointment at Princess Margaret, let's say. So it's that horrible gap in time where their doctor has said, this looks like ovarian cancer, we're going to refer you to Princess Margaret, and they're just waiting for that first appointment. And so for a lot of people, we were talking about personalities of knowledge and getting information. A lot of people just want to get as much information as possible, and the wait is really unbearable. And so they will often call me to get some information. I get a lot of calls during treatment. This tends to be more about, just questions about, I don't know if my oncologist is saying we should do this. Does that sound right to you? And of course, I'm not a doctor or nurse. I have no access to their file, even if I was. So there's a lot of training around how would you go to your next appointment, have a list of your questions. This is, feel free to ask questions, go to patient education, try to refer back to the cancer center to get some of those questions answered. But I do sometimes get those. I'll also get questions about how do I access particular drugs. So for example, Avastin and Lynparza are not covered. There aren't a lot of drug options for this particular cancer. So I do get a lot of questions about where are we in the process of approving olaparib, for example. So I'll get questions like that. And then of course, I think one of the biggest times I get calls is post-treatment, when those appointments come to an end. When they're sort of grappling with the psychosocial challenges of, oh my gosh, now life is supposed to go back to normal. My appointments are over, chemo is over, but I don't feel normal at all. And actually now the chickens are coming home to roost a bit emotionally. Now I'm starting to feel the stress of what I just went through. And it can be very confusing for people. They think that they're fine now. And in reality, they feel nothing but fine. They're feeling really stressed out, really anxious. Why isn't my oncologist following up on me more? Why are they not doing scans? All of these questions. Again, I do a lot of referring back to Princess Margaret, to the psychosocial oncology clinic, really making sure they understand they can self-refer. There are supports here. There are places like Elixir across the street. There are really trying to make sure that they understand some of the supports that are available, and also try to normalize what they're feeling and say, this is totally normal that you're feeling this way, that this is such a common response after treatment is over. I also make sure that they know about support organizations in their community. So this is Toronto specific, but Gilda's Club, Wellspring, know that there are organizations that you can go to help transition from the Cancer Center into your community. And then, of course, specific support groups. So a lot of times, and I'll talk a bit about this in a moment, that they feel, breast cancer's everywhere. I want to talk to people who've gone through exactly what I've gone through, and so referring them to a peer support group like the OVCA Peers that meets at Gilda's Club, or a professionally facilitated support group, which is at Wellspring downtown as well. So really trying to just connect them. So I'm also trying to learn about, as much as I can, about what supports you might have at Princess Margaret, or that you know about in the community, so I can better refer back as well. Because again, we are not counselors, we're not social workers, we're not doctors or nurses. We are really there to try to just connect them to that community. We also provide really, I think, high quality information about ovarian cancer. So again, they're not going to take in all the information at their appointments with their oncologist. They're going through treatment. They're just not digesting it necessarily. So we do have some resources that are available and free. I wanted to point out By Your Side and Still By Your Side. So By Your Side is a guide, and it can be found in the library here at Princess Margaret. It's when women are initially diagnosed with ovarian cancer, that initial diagnosis. This is a lot of information about who is your healthcare team, what are some of the side effects of treatment, what are some of the, psychosocial issues you might be facing. So it's a really great resource for women when they're newly diagnosed. And then we also have Still By Your Side, which is for women when they're diagnosed with recurrence. So we used to have You Are Not Alone, which was one guide that covered everything. And then we, very quickly realized that recurrence is its own situation with its own unique issues that come up. And so we created an entirely new guide just for recurrence. So we encourage, we really want to get these into the hands of women at the time of their diagnosis. And any help you can, I don't know what your role might be, but referring them down to the library, or if you're on a gynae-onc ward, having these in clinic to distribute would be great. We also have webinars on our website, and so these I think are fantastic resources if people learn this way, if they like to receive their information this way. Webinars done by gynae-oncologists, gynae-onc nurses, specialists in sexuality and intimacy who do specific webinars that are done live, but then also recorded and on our website. So there's a whole list. We also have a lot on research. So we have ovarian cancer researchers talking about their work. So if people have questions about immunotherapy and so on, they can hear it right from the person doing the research or from the oncologist. And so those are all on our website, and we encourage women to explore those. And we will have, and their family members who often have a lot of questions too. And we will be doing a series on recurrence this fall. There's one coming up, it's Ovarian Cancer 101, that's coming up in October, but then beyond that, there'll be a whole series on recurrence, fear of recurrence, living with recurrence, that kind of thing in the fall. So those are great. And we do workshops, patient education days. We really try to just have that information out there so that people have what they're looking for. One of the other things we've done in the area of, it's kind of support and awareness, it bridges it, is to, again, we see pink everywhere but no teal. And this was a specific comment about the cancer center that they were at. This was in Windsor. I heard somebody say this, I just see pink everywhere, no teal. So we really have tried to work with different cancer centers to have information tables at various times where survivors themselves or volunteers who are connected to the disease can actually just be there, answer questions, have that visibility, and hopefully women who are going through the treatment, they feel like they're not so alone, and they get a sense of some of the supports that are available for them. So that's been great, and we've been working with Michelle at Princess Margaret to have a table there, and it's been really a fantastic way for us to reach out. We focus a lot on awareness raising in the community, so we'll have things like World Ovarian Cancer Day, or September is Ovarian Cancer Awareness Month. But we did realize that community level awareness raising is fun, and it's great. It does a lot of good stuff, but we really needed something more. because through our polling, we found out in our surveys of Canadians, we found out that there wasn't a lot of familiarity with ovarian cancer. We researched, we worked with a company that helped us to discover this. If you look at this sort of these quadrants, you have comfortable, engaging, and that's where breast cancer sits. And then you've got clinical and taboo, and we are way up in the corner. So basically, when we talk about ovarian cancer, we've been talking about it very clinically. It feels very taboo to people because it's a gynae cancer. It's not a very approachable topic for people. They don't feel comfortable talking about it. We needed to do something for the general public, for people who had no connection to this disease, who couldn't care less about it, to take notice and to see why this is something that needs investment, why we need to pay attention, why we need to learn more about it. So we worked with Grey Canada on a campaign called Lady Balls, which was launched in December, January of this past year. And love it or hate it, and I've received all the calls, love it or hate it, this campaign did enormous things for ovarian cancer in Canada. Basically the impact, we had so many media impressions. We were on the National, we were in the Globe and Mail, we were in Maclean's magazine, we were everywhere with these stories and with coverage and every chance we got. Now, in all honesty, they were interested in the controversy because some people just didn't like this campaign at all. And so we were getting calls about the controversy because that was the story for the media. But while we were there, we were able to say, the PAP is not a screening test for ovarian cancer. This is the research investment in this disease. More needs to be done. And so we just kept getting more and more opportunity. And we had 118% increase in requests from people who never had heard of us before, despite having the disease themselves. We had one woman in BC who pulled her car over listening to the radio ad. She had ovarian cancer herself, and she just said, I've never heard anyone talk about this disease like this. And she donated $100,000 to us for the campaign specifically, because she just kept wanting it to get out there because no one ever talked about ovarian cancer. What I always say, because people say, why are you calling them lady balls? People are either offended at the male genital, why are we using male terms to describe women's bodies? Why, it's demeaning, And what I always say is we've used ovaries, and we're never going to stop using the word ovaries, but no one has ever cared. No media, nobody, unless you're personally touched by this disease, has ever cared about our messages until now. So I don't like the word lady. I think, I just kind of, whatever. I'm not really thrilled with lady balls, but I will use it because it's actually getting attention. And Carol LeVay, who's up there, Carol, she has said, she was at Lobby Day at Parliament Hill, and she has no more treatment options left. And she had lady balls tattooed on her arm, and she's got a teal ribbon tattooed on the other arm. And for her, this is all about strength, right? And so she went to her chemo sessions with a big poster about lady balls. For her, it's this rallying cry of strength for a story that has typically been told in a more of a sad way. And so it has been a really interesting campaign for us and very effective. In terms of our education work, I'm not going to go into a lot of detail because this isn't as relevant probably for some of you in this audience. But we do focus on educating healthcare professionals, future healthcare professionals, and women, again, who are at that heightened risk of inherited genetic mutations. And I'll talk about the MPs in a second anyway. Research, again, I'm going to go over this fairly quickly, but we do focus a lot on research. We are a small organization, so we really try to, our strategy around research is around capacity building. So not just throwing out a grant, but actually working with organizations who will, match our grant funding. We'll fund training, like student researchers. We'll fund the tissue banks, so making sure that researchers actually have the clinical data to do their research across the country. I'm just going to go through. So yeah, we really want to train the future researchers. So if there's funding for the student researchers, hopefully they'll look at this as an area they want to go into because they know that there's research funding available. We were really pleased because when we partnered with the Canadian Research Society, we were able to actually, they were calling for ovarian cancer research because of our grants. They matched it as well. But then they got so many applications around ovarian cancer research that they actually started using their own funding to fund the grants as well. So we're thrilled with that. We fund a chair of ovarian cancer research in Ottawa, etc. But we do know that more has to be done. So we haven't had any major treatment breakthroughs really since the 90s. Outcomes haven't changed significantly for 50 years. So we are stomping. We are going to Parliament Hill. We're going to Queen's Park, and we're trying to get our message across. And just to give you a sense, and this isn't a competition, this is about look what can happen when you invest in research. Ovarian cancer research in 2013 received $13.8 million in funding, prostate 36.5, and breast 74.2 million. And sometimes people will say, well, breast is so much more common. You said that yourself. So this breakdown makes some sense. But when you do look at the mortality rates, it really does show that there is an unmet need with ovarian cancer. Breast and prostate have done amazing things because of the advocacy work and awareness work they've done and that investment in research. And now ovarian cancer is long overdue for its turn in this. So we are focusing a lot on government relationships. I looked at Justin Trudeau and I'm focusing on this relationship with Justin. But we went to Parliament Hill. We met with over 40 MPs and senators and policy advisors to talk about the need for ovarian cancer research funding. We also were there to fight against genetic discrimination, because there was a bill that has had its second reading in the House to protect Canadians against having their genetic information form a basis of discrimination. And provincially, we're also very interested we speak with MPPs about funding for new treatments. So I mentioned olaparib and Avastin, really trying to say, like, look, we need more funding. You need to cover these drugs when they come through to you, and also access to genetic testing. So we are sort of pushing a lot of our education focus in that direction as well. So in closing, before I open it up to questions, really just really trying to make sure that you know what we can provide in whatever context you're here. We have a lot of resources, a lot of supports. There's a lot of ways for people to get involved if they want to. If you're talking to patients, just even if they don't have anything specific, I am more than happy to just talk to them on the phone and let them vent about the experiences they've had and share their stories as well. And I encourage you to let me know about, because of our advocacy work, if there are gaps in the system or if you're experiencing anything specific in your context here, let me know about that, and we can try to filter that to our government relations work. And just collaborating with us. We love doing education events and campaigns for your patients, and we're happy to collaborate and to find ways to work together. So I hope that has addressed what you were here to come and learn about. But again, I think we have some time to take some questions. So are there any questions or comments?
I have a question about your telephone support.
Yeah.
Is someone there at all times to answer the phone?
No, it's like a 9 to 5 office. So we strive to answer within 24 hours.
Okay.
Yeah. There's always a voicemail. It's mine, and so they can leave a message there, and then I get back to them. Yep.
Can the cyst on the ovaries be a marker for this ovarian cancer?
Sorry, is which a marker?
The cyst, regular cyst on the ovaries.
Oh, a regular cyst?
Yeah.
I don't think, I'm not a clinician by any stretch or a researcher. My sense is that ovarian cysts are quite common and quite benign, and there's no relationship that I know through research that shows that there is a big correlation. It's quite a different situation there.
Thank you.
Yeah.
Can a lady who is not so sure of her family history go and request a BRCA test done?
I think if you want to pay for something, if you want to pay for the test, you can. That is and a lot of people go to the US for that if they don't have a family history. There are, I think, 14 criteria, though, that, so on the first floor of Princess Margaret, where they have the familial breast and ovarian cancer clinic there, I understand, like, you would get a referral from your family doctor. Typically, there's some strength to the family history at that point. And they would go through the criteria. I've gone through it myself, actually, and they put you through a little computer and it spits out your probability, and that dictates whether or not this is a covered test for you. But my sense is not just anybody can. I know there are people who are pushing to have BRCA testing for every woman over the age of 18 in the province. So I think there's a lot of incentive for that, because we certainly don't test. There's certainly a lot of women with BRCA mutations walking around out there who aren't being tested. But my sense is that you can't just go in and say, I don't have any family history, please test me, and then that would be covered.
And how expensive is the test?
I want to say, I am guessing, I hate that this is being taped, I am guessing it's around $1,500, $1,300. I understand, but maybe not. Is that about, yeah, it's, but again, there's a lot of, like, people are now going through the states, there's like, go test me, and, they're getting their tests online. It's becoming much more available for people who would like to do it that way. But of course, there is a pull to, make sure you're getting the counseling and the support that you need to, like there's that side of the equation too, where you want to talk to your doctor and want to make sure, that you are ready to handle the results that come back.
So I had a question, but I'm also one of the genetic counselors who works on the first floor.
I knew someone would be here. I'm like,
we have to come support you, right? And what Cailey's saying is correct. Like we would go through if there's any, looking at the different criteria. There's 13 criteria that we would use. And if someone is not eligible for testing, there are ways that they can pay for it. In Canada, you're right about the costing. Some places are. Some people are going to the States and it can be cheaper, but the testing's a little bit different, and also you still need a physician to order it, so it's not always so easy. But the genetics people could go through that in detail with somebody. Also, we've partnered with Ovarian Cancer Canada. I don't know, I came in late, so I'm not sure, Cailey, if you mentioned this. There's a Prevent Ovarian Cancer program because not everyone can access testing if their relative is deceased, and so that's a way that we are trying to help increase access of genetic testing for the BRCA1 and BRCA2 mutations to women who may not be otherwise eligible for the ministry testing, and that's something that's covered. So there are programs like that where people can go through. So my question was going to be, you mentioned advocacy for increasing access to BRCA testing. I was just curious to know what that was and if there were conversations with the Prime Minister.
we didn't talk to the Prime. We didn't talk federally. That was more of a provincial level, and we are starting our. We're working with GOC, we're working with different organizations and genetic counselors to figure out what are those systemic barriers, because that is probably the most complex ask we have because of funding and how that gets funded. So that is at a provincial level at this point, and at baby stages. I have a question for you, though, because this comes up all the time. So can people self-refer to, if their family doctor says, I don't think you've got enough here, could someone self-refer or no?
So it depends on the clinic.
Okay.
There's multiple clinics in the province and across the country. In our clinic, we will accept self-referrals from someone who, if a family member's been seen and perhaps we said this person needs to have testing, or if there's a mutation in the family.
Right.
Otherwise, we really try to get a referral. If someone calls and they're desperate, potentially we would see them anyways, but we try to get a referral where we can, just in terms of our own kind of billing and processes and that.
Got it. Okay, thank you.
So as far as the treatment goes, removal of the ovary is always necessary, or?
I think I want to say no, because I think I have heard, especially if you're of childbearing years, it would totally depend on the spread, I would think. So I think it would be different. It's very common that would be. But there is more of if you're coming from a fertility sparing perspective on this, you're talking about treatment of ovarian cancer, though. Right. Not the preventative business. But so in terms of if you have ovarian cancer, I think it's very typical that the ovaries are removed, and a lot is removed depending on the spread of the disease. But I don't want to say in every single case, because there's certainly, and at an early stage, it is caught in early stage. It's not always late stage, and in that case, it could be contained to the left ovary, and so they would preserve it. But that is getting into sort of discussions with your oncologist and what the best treatment plan would be, which is outside of my expertise.
I just have one more question about your latest book, Still on Your Side. There's no title on the book.
No. So there's no title on the book.
Any particular reason why?
Yes. So there's two reasons. There's two reasons. So one is, the reason we did it by your side is we worked with women with the disease in developing the book. And one of the things they said was they wanted the discretion to take the cover off, because they didn't want to be on the TTC and everyone sees that they're reading a book about having ovarian cancer. So that was part of it. And I'll be quite frank, these get messy in libraries and things like that, so they were getting ripped all the time. And so when it came to and they're also expensive, because these are about $20 to produce for us, so that's a lot for us. So that was the other reason why. It was a big debate, because the title is only on the side, so when you've got it on display. Now, the other thing is we really do want this to be quite targeted distribution. So it doesn't totally upset me that there's no titles or that it's not, because we don't want people just picking these up because it looks kind of interesting to read. So it's very much, and in other cancer centers, I'll just tell you, it works a little differently. So these are typically in the gynae clinic, in the nursing station, so that at the beginning of the day, they will actually go through the list of patients. They'll say, okay, this person's being diagnosed for the first time. I'll put this book in her file, like with the file, and it's handed by the nurse or the oncologist to the patient. So it's more of a direct approach that way. So it's not as necessary to have that cover, but I do appreciate it. It does look wonky, like even on my bookshelf, it just looks, kind of bare.
Okay.
Yeah.
Are there any other questions?
Can ultrasound not be used as a screening test?
Well, they've done a lot of research in this area, especially in the UK. They had a 12-year study where they looked at all like combinations of ultrasound, CA-125, and they had, I'm terrible at remembering all the details, but they had all these different groups where they followed them for years and years and years, and there was so much hope that something was going to trigger okay, this is the screening test. Like if we gave every woman an transvaginal ultrasound and a CA-125. But at the end of this 12-year massive study, it was viewed as not being effective enough as a screening test for the general public. And a lot of it is, and I'm now like, a lot of this is, so what the CA-125 is elevated and the transvaginal ultrasound shows a little something. Well, what do you perform surgery? So there was actually damage done to the general public of women who had had surgery and complications. So it's discussing whether or not something is effective as a screening tool for the general well population is pretty complex in terms of the resources, but also the safety of the test on the women involved. But they're certainly looking, they're certainly looking at the transvaginal ultrasound as a screening, like trying to figure out what is the combination that could be used safely and effectively. Yeah?
So you mentioned that it evolves quite quickly. What are we talking, like months, weeks?
I don't know. I was talking to someone yesterday who her doctor said she started having symptoms in April, and he told her it's probably been about 3 months, right? But it can be different for everybody. And the thing is that this cancer cells can slough off in the abdomen and nothing, and your body fights it, and it's not. So it's about the reproduction of the cancer cells as well in the abdomen, and where are they landing to cause the symptom, etc. But it's I don't know timelines. Again,
More based on like the cell cycle.
The English major over here. Yes, that's right. Sure. Yeah, no, I'm so sorry I don't know the technical stuff, but it's, but it can be quite quick. And in other women, like, I've met women where it has been self-contained and it's gone up to her sternum and pushed on her lungs. And it was years and years that she's had, symptoms, and then she went in for surgery and they staged her at stage 1. Like it just, so it's just so different, and depending on the kind and everything else. So I think it is kind of different for everybody, but it just can be. It gets women get so upset at themselves for not going over bloating, let's say. And it might not have even been about the cancer, but they just think this must have been in me for so long. I'm stage 3. I should have picked up on it. My doctor should have picked up on it. And quite frankly, it's, the majority of times a doctor sees someone with bloating or with abdominal pain, it's not, ovarian cancer. But that's the importance of trying to get that 3-week period, the diagnostic tests available, so we can at least do a differential diagnosis, get it off the table, and figure out what it is, so that women aren't spending, like women can spend months, 2 years at a urologist because they're having all these urinary symptoms. And for the urologist or the GI specialist, they're in their box of specialization and they're just looking for IBS, and they're like, they're looking at this as a gastro issue. And so women can go a long, long time going to these specialists and they never think about ovarian cancer. So it's really trying to make sure that even if it's a possibility, let's do these 3 tests, get that out of the way, and then figure it out. Thank you. Thanks.